Well, we are going to start the questions and answers session about the presentation that we have just seen. The first question about this is, what is the frequency of severe bradycardia with phenylephrine? As we have been seeing, phenylephrine is an alpha-1 direct vasopressor, and it can cause bradycardia. It would be a baroreflex, but it is bradycardia, and usually it's not severe. Also, this bradycardia is not frequent. In this study that I shared with you in my presentation, we can see that in the 50 micrograms per minute, it's 0%. It does not appear bradycardia, and they are not talking about severe bradycardia, but only bradycardia. Also, as we were saying, it is dose dependent. It, yes, can go to 32% in higher infusion rates, 75 micrograms per minute or 100 micrograms per minute. But we know that it is not frequent if we use phenylephrine right. Also, I wanted to remind that usually when bradycardia appears, it usually means that phenylephrine is being used late and in excessive doses. And in the international consensus statement, we know that they say that when we see that heart rate is decreasing, we should decrease the infusion. How to avoid bradycardia? Well, this is the next question, how to avoid bradycardia, and it has been said in the first question. Just to repeat it, I think that it is important that we use phenylephrine prophylactically and not late and in the adequate doses. As I was saying in my presentation, I think that phenylephrine is a very safe drug, but it is a drug which we cannot make mistakes. We cannot afford to make a mistake of dilutions, for example, because if we give 500 micrograms instead of 50 micrograms, we are going to have a severe bradycardia. But if we avoid being late and having too large doses of phenylephrine, the usual thing is that we do not see bradycardia and we do not see severe bradycardia. And about avoiding bradycardia, I wanted to add in this Q&A session a little review on this thing that I was saying in my presentation, that was combining the three tools that we have. Because if we have better hemodynamic status given by all the tools that we can combine, it is less likely to appear this bradycardia or to appear a hypotension that leads to a bigger infusion and to these things that can complicate the situation. And these tools, just to review them, were the non-pharmacological measures to reduce inferior vena cava compression and venous pulling in the legs with the left tilt of 15 degrees, the left uterus displacement, and the leg compression systems. All of them have a lot of scientific evidence supporting their use. And the other thing would be the fluid administration. We know that the crystalloid preload that was preconized in the 60s is now substituted by a colloid preload of 500 milliliters, or by a crystalloid colloid of 1000 milliliters. In my clinical practice, what I do is the colloid preload of 500 milliliters. It was said in the presentation, but we also know that we have tools that we can use if we have bradycardia, and if it appears, we can treat it with atropine or with ephedrine if it is associated with hypertension. Well, what is my opinion regarding the current status of norepinephrine versus phenylephrine? Well, Comparing phenylephrine with noradrenaline, we know that phenylephrine, as we have already said, is an alpha-1 direct vasopressor with immediate onset of action and intermediate duration of action. And the big problem, or the problem that we see in phenylephrine, is the baroreflex-mediated bradycardia. So it has been suggested that noradrenaline has some benefits similar to phenylephrine because it has a direct set of action, it has an immediate onset of action. And what makes the difference between noradrenaline and phenylephrine is that noradrenaline has some beta effect. This has been thinked as a solution to this baroreflex-mediated bradycardia. So what is the thing lacking from evidence to use noradrenaline in obstetric anesthesia? Well, until now it has not been very studied, especially regarding the effects on the fetus. I do not feel very entitled to talk about the use of noradrenaline in obstetric anesthesia because I am used to administering noradrenaline only in continuous perfusion and in a central line. So I do not really use it in my clinical practice, but there has been some recent research about this, and I wanted to share this study with you. It was made by Ki very recently in 2020, and it compared norepinephrine to phenylephrine, especially regarding neonatal outcome. That was what I was saying that was lacking from evidence for the use of noradrenaline in obstetric anesthesia, and the conclusions were favoring norepinephrine and saying norepinephrine was non-inferior to phenylephrine for neonatal outcome assessed by the umbilical arterial pH. And these results, as they say, provide high-quality evidence supporting the fetal safety of the norepinephrine in obstetric anesthesia. So maybe in the future we will be seeing more studies like this, and maybe this is an open door to the use of noradrenaline in obstetric anesthesia. Well, what is the clinical recommendation on the maximum dose of ephedrine to be used? Well, the answer is clear in all in the international consensus statement and in all the scientific evidence that we have, in the data we have. 15 milligrams is said to be the maximum dose recommended to avoid significant fetal acidosis. We know that ephedrine was the vasopressor chosen to be used in obstetric anesthesia from the 70s. This was favored because of the first studies with vasopressors in obstetricia were made in animal models, in sheep models, and they favored ephedrine. But once we started to study ephedrine in the human patient, we started to see that phenylephrine was superior to it in some things. And I wanted to show these studies that were very, very rapidly referred to in my presentation, but I wanted to stop to talk about them now. Because there is a lot of evidence that placental transfer is greater with ephedrine than with phenylephrine. And another thing is that phenylephrine provides an improved fetal acid basis status versus ephedrine. So 15 milligrams is the maximum dose to avoid significant fetal acidosis, as we were saying. Excuse me. But ephedrine is recommended in the international consensus statement as the second-line vasopressor, and I think that we should avoid its use as a first-line vasopressor. Why should we do prophylaxis? Well, prophylactic treatment has demonstrated benefit with the incidence of hypotension, with a lot of scientific evidence. Also, it has decreased nausea and vomiting in the patient undergoing C-section, which is important. And I wanted to remind the effects of hypotension, because it's important that we know that hypotension in our patients has important effects. In the mother, it can lead to nausea and vomiting, to dyspnea, dizziness, and more serious effects like loss of consciousness, which be very serious, especially if it leads to aspiration, and not to talk about hemodynamic collapse, which would be the most serious expression of this hypotension in the mother. And also in the fetus or the neonate, we have seen that hypotension can lead to acidosis, changes in fetal heart rate, low Apgar scores, and increase on the frequency of the need of neonatal ICU or cerebral palsy, or of course death. Also, just to remind this, that was also said in my presentation, we know that duration has more importance than severity, talking about hypotension. And here I presented 3 studies that showed this, especially this one that showed that hypotension lasting more than 4 minutes can have neurobehavioral changes at 4 to 7 days of life. What is the ideal phenylephrine dose for boluses? Well, first I wanted to share the opinion of the international consensus statement. This is a slide from my presentation, as we have seen, and they recommend, when they talk about a bolus regime, they recommend boluses of 50 to 100 micrograms. What is my opinion? In my clinical practice, I prefer to use a lot of boluses of 50 micrograms rather than using less boluses of 100 micrograms. I never use larger doses of 100 micrograms, but if I have to choose, what I do in my clinical practice is to use boluses of 50 micrograms, and I measure non-invasive blood pressure every 1 minute. If I have hypotension, I measure it every 1 minute, and use boluses of 50 micrograms as much as I need. Well, thank you very much for your attention. I hope that you have enjoyed this session, and that the things that were presented were clear, and thank you very much for your attention.